your host, Dr. Chana Davis. I'm a geneticist and contributing writer at Those Nerdy Girls. My guest today is Dr. Sarah Coles, a family physician and fellow nerdy girl. We are going to be getting into the nitty-gritty of cancer screening, and we'll be talking about the pros and cons. We'll be talking about the latest guidelines, why they keep changing. Sarah and I bring different perspectives to the table. I used to work in cancer early detection research, and Sarah has extensive clinical experience guiding her patients. Sarah, can you briefly introduce yourself?
Of course. Good morning, everybody. I am Dr. Sarah Coles. I'm a family physician and educator at North Country Healthcare in Flagstaff, Arizona, an associate professor at the University of Arizona College of Medicine in Phoenix. It's a mouthful. My particular areas of interest and why I'm talking about this today is because I really love evidence-based medicine and primary care and how we take evidence and make decisions to make recommendations, things like what should we screen for, why is it good or bad, or when should we make these choices. So I'm really excited to get to talk about this.
Awesome. Well, I think a good place to start is, what are the goals of cancer screening?
Yeah, it's such a good question. The goals of cancer screening are really twofold. First is to detect potential early or precancerous things prior to any symptoms where we have a chance to intervene. And then ideally to treat those cancers before they become bad. So our goal is to reduce morbidity and mortality, meaning that people die less from cancer, or if they do have to have a cancer, that they have less bad outcomes. So improved functional activities, better quality of life, those kinds of things.
And there's often a lot of confusion about screening and diagnosis. So they're not the same thing. And can you elaborate on the differences?
Yeah, I think this is such a good question because it really can be hard to wrap your mind around that screening and diagnosis are very different things. So, screening tests are primarily used for early detection of a disease or a risk factor. So, a positive screening test does not mean necessarily that you have that cancer or whatever disease state we're screening for. We need a diagnostic test then to tell us that. That's the more specific test that will tell us if it's true or not. So, screening tests are almost always followed up with a diagnostic test to find out if someone really does have that cancer. So, for example, a mammogram is a screening test for breast cancer. If someone has an abnormal mammogram, they need additional diagnostic tests to find out if that's real or not. Something like more images of the breast or biopsies of the breast tissue to look at those cells under a microscope and see if they have cancer.
Mm-hmm. So you think of a positive screening test as kind of like a caution, maybe.
Right.
Yeah.
A positive screening test means we need to look further to find out if something is there or not.
All right. So why don't we talk a bit about the benefits of cancer screening? Because maybe actually taking a step back, I'll give people a bit of the shape of the show. We're going to be giving some overarching messages and education about cancer screening. We're talking about harms, we're talking about benefits, and then we'll get a little bit more specific about guidelines, at what age you might start wanting to think about which cancer screening. And then we'll talk about dispelling some common myths and misconceptions about cancer screening. Sorry, I should have done that up front. So why don't we start with some of the positives?
Yeah, great.
Mm-hmm.
And Chana, do you want to take this?
Sure. Yeah, I can take this. I actually was digging around a bit to look for some numbers, of course, and I found there was a great study that came out, I think just last year, that looked at an estimate of the impact of cancer screening programs in the US over a roughly 25-year period. And they estimated that cancer screening saved between 12 and 16 million life years. This is with the people actually, this is a real world estimate based on how often people actually go for the screening that is recommended. And then they estimated that if people actually followed the screening guidelines put out by the US Preventative Services Task Force, it would be closer to 15 to 21 million life years. So that is a huge potential, a huge impact and a huge, even more untapped potential for people actually adhering to the screening guidelines. And I should note that this is from breast, colorectal, cervical, and lung cancer combined. And one of the things that really jumped out at me when I looked at these numbers is that the vast majority of those life saves are from cervical cancer. So that is a huge nod to pap smears. I hope everyone out there is getting their pap smears, because that is an incredible life-saving and relatively simple thing we can do. You want to add anything about the benefits, Sarah?
Yeah, I think it's so important to recognize, because I'm going to talk about harms of screening in a moment. That screening really does save lives. Screening help people live longer, happier, healthy lives, reduce significant cancers, and help people live longer, which is amazing. And seriously, shout out to cervical cancer screening about how well that has done at saving lives and
Mhm.
extending people's healthy life years. It really is incredible. I'm curious, and this is not the subject of today's conversation, but we'll see how that changes over time now that we have a vaccine to prevent cervical cancer. If cervical cancer screening will be less useful over time because the prevalence, how many people have cervical cancer, will go down.
Mm-hmm. And yeah, we also can't get into the details here, but here in BC, we just got at home pap smear kits that we can do, or a different type of testing that you can do at home for cancer screening. So that's a great, improvement of hopefully on access.
Yeah, there's so much potential for at-home screening, particularly for cervical cancer, by testing for that HPV or human papilloma virus. It's really exciting. I'm glad you all are getting access to that.
Mm-hmm. Okay, so as we already mentioned, we're going to be talking about both sides and really just to help open your eyes so you really appreciate the complexities of cancer screening. So Sarah, can you shed some lights on the potential harms of cancer screening?
Yes. And again, I'm going to talk a lot about harms, but I should reiterate, I love me some cancer screening. It really is important, and such a critical thing that we do in primary care and in populations at large. But not all screening is good all the time. So a lot of people assume that all screening is in someone's best interest, but that's not necessarily true. While screening can detect diseases in an earlier stage and may lead to opportunities to intervene, there are also harms that we have to consider when we're thinking about whether or not to screen for cancer. So there are a bunch of harms I'm going to talk about, one of which is the harms of the test itself, like additional radiation exposure for low dose CAT scans that we use to look for early lung cancer, or poking a hole in the colon during a colonoscopy where we're looking for colorectal cancer. All of those have potential harms for folks. Ideally, the harms are less likely than the benefit of that screening test. So we did a lot of time looking at what are the rates of those harms and how likely they are to impact someone.
Mm-hmm.
Screening tests can also get inaccurate test results, like false positives or being told that you might have a disease that you don't have, or false negatives and getting some maybe reassurance that you don't have a disease when you actually do. No screening test is perfect. So we have to balance what to do with those test results as well.
Mm-hmm.
Another big one I want to talk about is overdiagnosis of a disease state. And overdiagnosis is, I think, another one that's kind of challenging to wrap your brain around. But essentially, it's when you find a cancer that was unlikely to ever do anything negative to you in your life and would never have been found if we didn't screen for it. So some people just develop cancers that hang out and never go on to become a problem. They don't metastasize or spread. They don't kill you. They don't cause organ damage. They just are there. And we can find them by screening. We don't know when we screen which cancer is which is that cancer that's just going to like chill and which of that cancer that's going to be a problem. But we know that this happens, and this is a statistical model because there's a difference between the number of cancers that we diagnose and the death rates, even when we don't do anything about them. So overdiagnosis means that people can get treatment that they didn't need. Things like surgery or chemotherapy or radiation, all of which are not fun, and can have some serious health consequences for folks too.
Mm-hmm. Yeah, and I think that the tricky thing about this, like you mentioned, is you don't know when you find it. You don't even know after you treated it if that
Right?
treatment was necessary.
Yeah, we'll never know for that individual person,
Mm-hmm.
whether that cancer was a true cancer that was going to cause problems or an overdiagnosed cancer that we could have left alone and you would have lived a long, happy, healthy life,
Mm-hmm.
never having known about it, which can
Mm-hmm.
be really tricky.
Yeah.
I think another thing that comes up, which is maybe less intuitive, is the damage of disease labeling. So once we tell somebody that they have a disease state like a cancer, that itself can be harmful, having that identity attached to you. So if
Mm-hmm.
we tell someone that they have a cancer, they're far less likely to get other preventative or chronic needs met. So we're less likely to offer them other screenings for other cancers or treating their chronic conditions. And that's also harmful. And that's obviously a prejudice and a problem in the healthcare system, but is a real harm for people who are getting screened.
Mm-hmm.
And then the last one I want to share is just obviously the harms of treatment are real, right? People who need surgery or chemotherapy, all of these things can be harmful for folks, and they may not have chosen to get that treatment if they didn't know they had that cancer, for a variety of reasons, because maybe they weren't interested in pursuing that. And then, of course, all of the screening, it can be expensive, time consuming, and scary for people who are going through cancer screening.
Yeah. Well, I would say this is a topic I can share something personal because it's quite close to home. I've researched cancer screening for years, but I've only in my mid-40s started getting cancer screening. Well, I have been getting my pap smears, I should say, but I just started getting mammograms when I turned 45. So I had my second one about a month ago, and I got a voicemail. I was actually out of town, and I got a voicemail follow-up telling me, just come back. We want more testing. We want you to come back for another ultrasound and mammogram. So that was obviously anxiety producing, because that's what you want, is to get a letter 2 weeks later, saying everything's fine. So I didn't get the "you're fine" letter. I got the "come back" letter. And I still don't actually know the outcome. So I'm in limbo. But I just want to talk about this because it was so, it's a very common experience, actually. They didn't give me any context at the time, especially not the voicemail, which was from the testing center. So I ended up doing a bunch of research on my own. And, I knew that false positives existed. I just didn't know how common they were until I was in this boat. And I found out that it's something like 1 in 10 mammograms will get a call back. And, at least 90% of those are false positives. And they didn't tell me that information at the time. I did eventually get a letter with that information. The letter told me that 94 out of 100 women who get called back will eventually find out everything's normal. But there really needs to be, I think, more education and communication, especially up front. As soon as you get the information, that's when you're going to be the most anxious. And also frustrating here in BC is that I have to wait 2 months to have my follow-up test. So,
oh no.
Yes. So I am in limbo for 2 months. And thank goodness I have the numbers, because I know 94% chance it's okay. And I'm not obsessing over it, but some people might be obsessing over it, right? And also some people might not live near testing, and might be a big deal to come back and get the follow-up test. So this is it's a very real burden. And when I posted a bit about this on social media, I had a bunch of friends tell me about having the same experience, but they never told me until I shared mine. So it's incredibly common, and people kind of feel like they're alone in it. It's very real. And I hope mine turns out to be a false positive, obviously, but even a false positive is not a positive experience.
No, and I'm so sorry you're going through that. It's terrifying to get an abnormal mammogram result, because all of us immediately jump to "I have cancer," right? Like our brains go to that worst case scenario. Even sometimes when you have that information, when you know that 94% of the time it's going to be okay. But as you said, now there's a 2-month wait. You still have to go get additional images, potentially a biopsy. I hope not. Fingers crossed for you. Which is it's an awful position to be in. I try to make sure I tell my patients in advance when we're ordering the mammogram that, hey, there's a pretty good chance that this will come back with a false positive, which means that we have to do more images or biopsies. But you should know that going in, so that when you get that letter, you get that phone call, it's not, oh my gosh, something is going to happen that's awful. But even with that prep, right, it's still real scary for folks.
It is. Yeah. And I think in your 40s, this is especially common, right? When when I'm talking about harms versus benefits, that ratio is a little more gray, which is why screening in your 40s is something that we see not a strong consensus, both within a country and across countries.
Yeah, let's talk about screening in your 40s with mammograms. I think that's a really good segue into numbers and thinking about what are some of the harms about screening. So let's say we have 1,000 women who are screened for breast cancer using a mammogram every 2 years, starting at the age of 40 instead of 50, which in the United States was the prior recommendation more broadly. So by moving it down 10 years, we would prevent about 1 additional breast cancer death. But 36% of these women will have a false positive, and 7% of them will have a false positive that's scary enough that it will require them to undergo a biopsy. And as you mentioned, there's so much anxiety, additional tests that themselves can cause pain or infection or bleeding, having to take time off of work or other activities, travel if you don't live in a community that you can get these things done. It's a big deal. It's a big cost to have that false positive. In that same group of women, 14 of them will have an overdiagnosed breast cancer. Those breast cancers that didn't matter, didn't really do anything, wasn't going to change anything anyway, which is 2 more overdiagnosed breast cancers than if we start at age 50. So there's a trade-off when we're picking which groups to get which cancer screenings for. And that's really hard to decide who gets what and when. And then what is the cost worth to prevent one additional breast cancer death? Because everything has a harm. So what are we willing to do in cost or in other harms to make that, to save that one life?
Yeah. And that, like you said earlier, the people who are overdiagnosed don't know it. And so it's such a tricky space because you have so much advocacy for more screening because everyone who was treated and caught early assumes that that was an appropriate life-saving screen. And they don't realize that some significant fraction of those women who had something caught and treated actually never needed to have it caught and treated.
Right. It's for the folks who are experiencing it, it feels life-saving and you never know if it really was for you or not. This is an example of what's called lead time bias, right? So we catch something early at some point and it looks like you live longer as a result of catching it, but it didn't actually change your risk of dying or having a bad outcome. And we can't tell who's who.
That you have to look at a population level statistic to compare how many cancers did we catch compared to what would have happened had we not been screening to know that this was happening.
It's tough. I don't envy all the folks who have to make these decisions all the time for big population choices because it's a lot of things to weigh.
It is, absolutely. I'm going to drop a link into the chat with to support what you just shared there. Some of those stats. So let's keep things moving and talk about what screenings are recommended. So what are the populations in which the benefits outweigh the harms, kind of at a population level, and that's kind of where screening is recommended, right?
Yeah, absolutely. So as a note, guidelines differ slightly from country to country and between organizations, and we'll talk about in a minute why that is. But in general, in North America, we recommend for screening for breast, cervical, lung, and colorectal cancer. For cervical cancer, we tend to start younger, around the age of 21. The other screenings happen a little bit later in your 40s or 50s to get started on those screenings. We are doing these age-based screens based on the group that is the highest risk of developing those cancers. So cervical cancer happens in younger folks with a cervix, whereas these other cancers tend to happen a little bit later in life. So mid to later life, 40s, 50s, and older. So we don't screen for them a lot earlier than that.
So I dropped in a link from the U.S. Preventative Services Task Force. Is that where someone can click on that and look all this up for themselves?
And you can find all of your all your cancer screenings, including cervical cancer, recommendations by age, by other risk factors, like things, do you smoke cigarettes or use tobacco? Do you have other risk factors that would put you at a higher risk for breast or colon cancer that might change that recommendation just a little bit? So all of that can be found in that link.
Yeah, I was just going to say, so far you've talked about age, but in general, the paradigm for screening is that the benefits will outweigh the harms. That the higher your risk of actually having cancer, the more likely that getting the screening is going to be more beneficial compared to the harms. And so your age is one of the strongest risk factors for cancer, but so is family history, so is genetics, and so is smoking for lung cancer in particular.
Right. Yeah. We don't recommend lung cancer screening for people who have not used inhaled tobacco products because the likelihood for everybody else is much lower. The biggest risk factor for lung cancer is smoking.
Okay, let's talk a bit more about when screening is and is not recommended, because sometimes people say, that screening guidelines are too strict, right? That we should be screening more people younger, more people older. And actually, some people are quite surprised to see that screening has an upper limit on age. So can you explain why that is and elaborate a bit more on why we don't screen everyone for every cancer?
Absolutely. I think it's such a common question of how come we don't screen everybody all the time? Wouldn't it be great if we found all these things? And it's exactly as you said, we're balancing the benefits and harms of that screening test. So some groups are at higher risk of developing certain cancers than others and are more likely to have a benefit and less likely to have the harm from that test. Whereas other groups who might already be at a lower risk are much more likely to be harmed by the screening test than they are to really have a benefit. So let's take that older age cutoff, older folks as an example. So while older individuals are typically at increased risk for many cancers, because age is a big risk factor for developing cancer, screening doesn't always benefit older folks. As we get older, the mortality benefit, the less likely we are to die from a cancer screening, maybe less than younger folks. And the risk of the screening test itself might go up, like you're at a higher risk of getting a perforation on the colonoscopy. Or maybe you have another disease that makes it certain treatment options unacceptable. Like you have bad lung disease, and so you can't tolerate getting a lung cancer surgery if we were to find lung cancer with your lung cancer screening. So we want to make sure that as we're making broad general population-based guidelines, that we're thinking about that general balance of harm and benefit for folks. Some tests also just don't help anything. Like they don't really add anything. So we currently recommend against testicular cancer screening, even though it's one of the most common cancers in men aged 15 to 34. We used to have people do testicular cancer screening with self-examination or examinations by their clinician in the office. But what we found is that most cases were found accidentally by the patient or their partner, and that adding those screening exams didn't help anything. We weren't more likely to find that testicular cancer at an earlier age. Testicular cancer is also ridiculously treatable, which is great. So even if we find it in an advanced age, finding it earlier didn't help their chance of survival or quality of life. So screening didn't actually help that group. So now we're like, don't bother screening. We're more likely to find something that's not real and cause them to have procedures that they didn't need. Other screening tests are more likely to actively harm you. And so we don't want to do those either. So ovarian cancer screening would be on that list. We could screen for ovarian cancer using transvaginal ultrasounds, which are very uncomfortable, or testing for tumor markers in the blood. But neither test has been shown to help people actually live longer or healthier. And that positive predictive value, the likelihood the test is right, of the screening tests for ovarian cancers are super low, meaning that most women with a positive screening test don't have ovarian cancer, but all of those women are going to have some additional testing, which sometimes is surgery, to look at the ovaries, and that's actively harmful.
Yeah, ovarian cancer is one of the ones I worked in the most because there's such a need for early detection, and there's just so much potential value. But what I learned in my years in that field is that the cancers that are easier to detect in research are not necessarily the ones that are going to kill you. So if you can use the blood test to detect some big ball of cells that isn't the kind of tumor that is the ones that are really tiny early stage that are then going to explode and grow quickly and kill you. So it's
right.
When we do, often in research, we do our discoveries in like a different population, kind of a low bar population that have these big tumors that are not the same ones as 10 years earlier, what was percolating in someone who then died of ovarian cancer. So it's really complex.
It's so complex.
Yeah. But yeah, I know for anyone in this field, just that there's a ton of research being done. And really, I think the overall message here is it's not that we need more people to access current screening, is that we need better screening. We need to find, and this is what we're working on in early detection in my previous research, was we need to find markers of cancer that show up early and are super specific, that they don't show up in non-cancerous. And the problem is that finding specific markers is really hard because our bodies, our cells, they use kind of the same ingredient list, across our body. So we need to find something that's truly specific just to those cancer cells. And that can be really hard to find. But there's lots of research underway to find something more specific. It's just super challenging given the biology of these tumors. So we just need to be patient and keep putting money into research. And be careful about applying tools that do more harm than good.
Yeah, and I'm so grateful for all of these researchers who are doing this work because, as you said, it is so hard and sometimes can feel so thankless because you find something that then in practice won't be as useful as we would hope. So these people are doing just such incredible work to help us identify better screening tools so that our screening can have that tip so that the benefit outweighs the harm.
I can drop in a couple of links here on some of these recommendations that you just mentioned. And then I want to talk a bit, we have two last questions I wanted to cover. One is about sort of just the general nature of changing guidelines, which I think we've touched on. And the last is for you to talk about some of the questions that come up in clinical practice, some of your with your patients. So did you want to, let's see, we've got 5 minutes left. So maybe we can just do a quick answer to something we touched on earlier, which is why do cancer screening guidelines keep changing?
Yeah, and it's such a good question, and there's lots of answers. And so maybe we can do a post on this later with those nerdy girls to further answer this. But there's a couple big reasons. One of the big reasons is that we get new research, as Chana was mentioning. We find a new tool, we have better technology, something improves that improves our cancer screening to make it more sensitive and specific, to have fewer false positives and harms and better outcomes. We used to use chest x-rays to screen for lung cancer, and that didn't work at all. But the invention of the low-dose CT scan protocol changed all of that and made lung cancer screening really useful. Another reason that guidelines change is that our populations change. So the United States Preventive Services Task Force recently lowered the age for cancer screening for colon cancer from 50 to 45. And this was partly due to potentially increasing rates of colon cancer in younger individuals and an attempt to reduce racial inequities that we see in our population, as Black individuals are more likely to die from colon cancer than white individuals. But this also reflects another reason that cancer screening changes, and that's our values change. What we value in that cancer screening can change over time. So this organization changed that recommendation in a hope to try to reduce inequities, which is excellent. They didn't have new data. They didn't have new studies that would prove that this actually would do that. But their value changed. So they were willing to put that bet. They were willing to take some of those harms on in an attempt to try to decrease those inequities and improve disparities between groups. So remember that human beings make these recommendations, and we all make our judgments based not only on evidence, but our values about that. And so how we make those recommendations can change even based on the same evidence.
Sorry, just as you were talking, I found there was a Nerdy Girls post on the recent changing guidelines. And what they said is potentially they could change the lifetime risk from 2.5% to 2.4%, which may not seem like a lot, but at a population level, it's actually, these small changes at an individual level can translate to a big thing at a population level.
Yeah, and it's tricky, right? Because that also means that we're increasing the risk of harms by adding more people that are doing it. So someone has to make those balanced judgments.
Yeah, I don't envy that job either. So to wrap up, let's get practical and clinical and talk about some of the conversations that you have with your patients, and what are some of the things that come up. Sorry, let me rephrase the question. What are the things that come up, some of the common questions and concerns and misunderstandings that come up in your conversations with patients about cancer screening?
Yeah, what I hear a lot is, I feel great, so I don't need screening, which is not true. The goal of screening is to catch a cancer while you feel great. So that's the best time to do screening, is that you feel well, so that you have the best opportunity to catch something early, as well as intervene while you are healthy enough to tolerate those interventions like surgery, chemotherapy, or radiation. So feeling well is the best time to come in and talk to us about cancer screening. I think another one is screening always finds cancer early enough to cure it. And I really wish that were true, but unfortunately it just isn't. That's the ideal and certainly the goal, but doesn't always work out that way. Sometimes we'll catch a cancer that's later stage in the screening and it may not be curable. Sometimes we miss a cancer in the screening at a time we might have been able to intervene. It certainly doesn't mean don't screen, but it does mean that there are it's not a perfect shot every time to do that screening. I think the others we've already kind of talked about, like all screening is good screening. That's certainly not true. We want to be really cautious about who we screen and make sure that those benefits outweigh the harms. And as we mentioned, a positive result does not necessarily mean you have cancer. It means you get more tests, that we need to do the diagnostic test to find out if you do or not, or if it's something else that gave us a false positive.
I love that you're having conversations with patients before they get the test, so they're equipped for this, because that was not the case for me.
I learned early on to save myself and my patients some grief by having these conversations before we order the test, because it scared both of us to get these positive results. And we wanted to put us both in a better mental space.
So as we wrap up, let's, we've shared so much information today, but we also could only scratch the tip of the iceberg on this. So I'm going to drop in a couple of links. And Sarah, if you have any closing comments you want to add about your favorite resources, and to learn more about cancer screening and figure out, what's right for your situation.
Yeah, absolutely. Do check out the United States Preventive Services Task Force link. And all of those recommendations, they have a pros and cons section with numbers and pictures and things to help people make decisions. So it's very helpful. And I'll often go through with my patients. And if you have any questions, I would really encourage you to speak with your primary care clinician to talk about, is this cancer screening right for me? What are the benefits? What are the risks? Should I be doing this or should I wait? Are there other things we might be considering? So we love, as primary care, having these discussions. So please come in and talk to us about it.
Awesome. Well, thank you for all the work you do, both with your patients and as an educator and a nerdy girl.
You too.
It's a lot of fun helping people really appreciate the nuance in these conversations, because it's tricky to wrap your head around, and sometimes it takes more than one conversation.
Absolutely.
So I hope we help bring some clarity to some people out there today.
Well, thank you everybody for listening. We hope it was useful.
Yeah. See you next time. Bye. Turn this off. Oh. Okay. Trying to shut this down. Oh, here we go. Bye again.